Hello everybody and welcome to our module on immunosuppressants. The drugs that you will see most commonly used to suppress the immune system or to suppress inflammation are NSAIDs and steroids, and we have an entire separate module on these two classes of drugs. What I'm going to discuss in this module are less commonly used drugs to suppress the immune system. So these include calcineurin inhibitors like cyclosporin and tacrolimus, also sirolimus and methotrexate. We'll also talk about mycophenolate and cyclophosphamide. Finally, we'll finish with azathioprine, the TNF-alpha inhibitors, and hydroxychloroquine, which is actually a malaria drug, but it's often used in rheumatoid arthritis. And all of these drugs here are generally reserved for autoimmune disease or serious rheumatological conditions, and also they are sometimes used to prevent transplant rejection. So we'll start by talking about cyclosporin and tacrolimus, and you should think of these two drugs together because they both inhibit the enzyme calcineurin. Calcineurin is a very important enzyme for activating something called NFAT. NFAT stands for nuclear factor of activated T cells, and it's a very important transcription factor for many cytokines, in particular for IL-2. So calcineurin normally activates NFAT via dephosphorylation. I've illustrated that for you down here. It dephosphorylates by taking the phosphorus group away from NFAT, and then NFAT goes to the nucleus and it stimulates the production of IL-2 and other cytokines. So when you inhibit calcineurin, you will get decreased production of IL-2 and many cytokines, and that's how these drugs work. Most people just think of these drugs as calcineurin inhibitors, but if you drill down a little bit further, they work through slightly different mechanisms. Cyclosporin binds to molecules called cyclophilins, and the complex of cyclosporin and the cyclophilins inactivates calcineurin. Tacrolimus, on the other hand, binds to something called FK506 binding protein. When tacrolimus first came out, back when I was in training, it was actually called FK506, and later it was named tacrolimus. So it binds to the FK506 binding protein, and this complex is what inactivates calcineurin. The net result, though, is the same. Both drugs inactivate the enzyme calcineurin. Cyclosporin and tacrolimus are sometimes used in autoimmune diseases, and more commonly you'll see them used to prevent rejection of organ transplants. They both have relatively similar side effects, which we'll talk about in a minute. One of the most important things to know about these two drugs is that they are both metabolized via the cytochrome P450 system in the liver. This means that there are many drug-drug interactions that can raise or lower the levels of the two drugs. You can measure a cyclosporin or tacrolimus level in the plasma, and this is sometimes done. And then sometimes when another drug is added, it can increase or decrease the levels if it affects the P450 metabolic system. The most important and limiting side effect of both of these drugs is nephrotoxicity, and the reason this occurs is because they both cause vasoconstriction of the afferent and efferent arterioles and a decreased renal perfusion. As a result of the decreased renal perfusion, many patients develop hypertension on these drugs. The renal vasoconstriction leads to salt and water retention and high blood pressure. In this situation, the drug of choice to treat the hypertension is the calcium channel blocker diltiazem. The reason is because diltiazem is an inhibitor of the P450 system, so it will impair cyclosporin metabolism and raise the drug levels. As a result, you will be treating the hypertension with the diltiazem, and you can lower the dose of cyclosporin because diltiazem is blocking its metabolism and allowing you to use a lower dose that causes less nephrotoxicity. Other side effects of these drugs: they can raise the uric acid level and cause gout. They can cause hyperglycemia. They may impair the secretion of insulin, and they can sometimes cause neurotoxicity, which usually presents as a tremor. Cyclosporin has two unique side effects you should be aware of. Neither of these are reported with tacrolimus. The first one is gingival hyperplasia. If you look at this picture up here, you can see that this person's gums are growing down over their teeth. That is gingival hyperplasia. Now, the drug that classically causes this is the anti-seizure drug phenytoin, but you should also think of it with cyclosporin. And then the second unique side effect is hirsutism. This is a picture of a hirsutized woman here with a beard. Usually it's not this severe in people taking cyclosporin, but women who take this drug can notice hair growth and other features of hirsutism. Next, let's talk about sirolimus, which also goes by the name rapamycin. This drug is used in kidney transplant patients. It's also used in drug-eluting coronary stents, which we'll talk about in a minute. This drug inhibits something called mTOR, which stands for the mechanistic target of rapamycin. Sirolimus is called an mTOR inhibitor. The way it inhibits mTOR is it binds to FK binding protein. This is the same target as tacrolimus, and that's why its name sounds like tacrolimus. However, unlike tacrolimus, it does not inhibit calcineurin. It inhibits mTOR. Together with the FK binding protein, it blocks the function of mTOR, and this leads to a block in the response to IL-2 from B and T cells. It blocks the signaling pathways, and the cells arrest in the G1 to S phase, so there is no growth or proliferation of B cells or T cells. Side effects of sirolimus include anemia and thrombocytopenia and leukopenia, and we will see these type of side effects in many of the immune suppression drugs. Many of them exert their most potent effects on the most rapidly dividing cells in the body, and those are often the cells of the bone marrow, and therefore bone marrow suppression and loss of red cells and platelets and white cells is a common side effect of many of these drugs in this module. Other side effects of sirolimus include hyperlipidemia. The drug can inhibit lipoprotein lipase, and the drug can also cause hyperglycemia by inducing insulin resistance. Drug-eluting stents are coronary stents used to treat coronary artery disease, and they are coated with an anti-proliferative drug to blunt scar tissue growth. This is a process called restenosis. If you have a coronary artery like I'm drawing here with an obstructive plaque, you can treat the blockage by threading a wire across the plaque and then expanding a metal device called a stent. A stent looks like a piece of chicken wire, and it's collapsed when you put it across the blockage, and then you expand it to fill the coronary artery and restore blood flow. The problem is that the stents cause inflammation, and there can be scar tissue which grows over the stent and reobstructs the artery. As a result, companies have developed drug-coated stents that elute a small amount of an anti-proliferative agent to try and blunt this scar tissue overgrowth and avoid reobstructing the artery. So sirolimus is one of the drugs that's commonly used to coat drug-coated stents. Also a related compound called everolimus, and sometimes paclitaxel is used, which is another chemotherapy agent. Moving on, let's talk about our next immunosuppressive drug, which is methotrexate. Methotrexate, you may know, can be used as chemotherapy for some cancers, but it's also used to treat a number of autoimmune diseases. The mechanism of methotrexate is that it mimics folic acid, and you may know that folic acid is required for synthesis of nucleic acids in DNA. What methotrexate does is it inhibits dihydrofolate reductase, and in order to understand this, let's review a little bit of biochemistry. This structure on the left side of the screen is deoxyuridine monophosphate, and you may know that uridine is used in RNA but not in DNA. DNA, instead of uridine, uses thymidine. So deoxyuridine monophosphate can be converted to deoxythymidine monophosphate by way of the enzyme thymidylate synthase. For thymidylate synthase to carry out this function, it needs a ready supply of methylene tetrahydrofolate, and tetrahydrofolate comes from dihydrofolate via the enzyme dihydrofolate reductase. So if you inhibit this enzyme right here, thymidylate synthase will not be able to do its job, and thus you will have a decreased supply of thymidine for DNA, and you won't be able to synthesize DNA. And as we have seen before, this will have its greatest impact on rapidly dividing cells, which include those of the immune system. An important side effect of methotrexate is myelosuppression. You can see reduced red cell counts and platelets and white blood cell counts in patients taking this drug. You can reverse the myelosuppression with an agent called leucovorin, which is folinic acid. This is much more commonly done for cancer patients who are receiving high dosages of methotrexate to treat a malignancy. The reason that leucovorin reverses the myelosuppression is because it's converted to tetrahydrofolate, but it does not require dihydrofolate reductase. This is a process called the leucovorin rescue. If we go back to our map of the folate pathway here, what leucovorin does is it gets converted directly to tetrahydrofolate, and it bypasses the dihydrofolate reductase enzyme, which has been inhibited by methotrexate. This restores this cycle and allows cells to begin synthesizing thymidine again, and therefore they can begin synthesizing DNA again, and the white blood cell count will come back up. The leucovorin rescue obviously negates any beneficial effects of methotrexate on cancer cells, so it's typically done in a cycle where patients are given methotrexate and then they have a leucovorin rescue, and then they're given another cycle of methotrexate and so on to try and eliminate the malignancy. Another important side effect of methotrexate is stomatitis or mucositis, which usually presents as mouth soreness. This is a problem that occurs with many chemotherapy agents. Pathophysiology is believed to be due to DNA damage, which triggers cytokine release, and then the cytokines damage the local epithelium. There is a loss of mucosal integrity, and as a result, patients develop pain and bacterial growth, usually in their mouth. Treating mucositis is a major issue in patients receiving long-term chemotherapy. Methotrexate can also cause abnormal LFTs, and LFTs are usually monitored in patients taking this drug chronically for autoimmune disease, and it can also cause GI upset. Our next drug is mycophenolic acid, or mycophenolate. It also goes by the name Cellcept, and this drug inhibits the enzyme IMP dehydrogenase. IMP dehydrogenase is the rate-limiting step in purine synthesis for lymphocytes only. This makes this a very effective drug at suppressing B cell and T cell function. In addition, mycophenolate preferentially binds the type 2 isoform of IMP dehydrogenase, and this type 2 isoform is expressed by activated lymphocytes. This also makes it very effective at selective immune system suppression. If you look down at the bottom of the screen on the left side here, I've drawn the chemical structure of inosine monophosphate. Through a series of steps, it is converted into guanosine monophosphate, which is used as a building block for DNA. IMP dehydrogenase is a key enzyme in this pathway, and it's inhibited by mycophenolic acid. If this enzyme sounds familiar to you, that may be because it is also inhibited by the antiviral medication ribavirin. Ribavirin also decreases the available pool of guanosine monophosphate so that viruses have fewer nucleic acids with which to replicate. The net result of administering this drug is decreased availability of nucleotides, which leads to decreased DNA synthesis in T and B cells. Just like with many drugs in this module, bone marrow suppression is a side effect. You can also get GI side effects with this drug like nausea and cramping and abdominal pain. Our next immunosuppressant is cyclophosphamide. You may know that cyclophosphamide is used for chemotherapy, but it is also a very powerful immunosuppressant that's used in some autoimmune diseases, especially in vasculitis and glomerulonephritis. These are very severe autoimmune diseases, and oral cyclophosphamide is often used as therapy. It is a prodrug that needs to be bioactivated by the liver. The liver converts it to a type of structure called a phosphoramide mustard, and you may know that mustard gas was used for chemical warfare in World War I, and those toxic gases work the same way as cyclophosphamide. It's metabolized by the P450 system in the liver. It's called an alkylating agent, and the reason is because it adds an alkyl group, which is a carbon-hydrogen group, to the N7 position of guanine. This is the base guanine down here on the right side of the screen, and this is the nitrogen in the 7 position. So a carbon group gets added to this, and as a result, the DNA strands will cross-link. The guanine groups will link to other bases as a result of being alkylated. This will lead to an inhibition of DNA replication, and eventually cells will begin to die. Once again, myelosuppression is an important side effect of this drug, just as it is for many other drugs in this module. So you can see a low white blood cell count, a low hematocrit, and a low platelet count in patients who are on cyclophosphamide. A unique side effect of this drug is hemorrhagic cystitis. There is a metabolite of cyclophosphamide called acrolein, which is toxic to the bladder. So patients taking cyclophosphamide can develop hemorrhagic cystitis, and that will present as hematuria, possibly with dysuria on urination. There's a lower risk if the patient receives hydration, so patients getting cyclophosphamide for chemotherapy are often hydrated, and then you can also lower the risk by administering a substance called mesna. Mesna is sodium 2-mercaptoethene sulfonate, and it binds and inactivates acrolein in the urine, so if you give patients hydration and mesna, they are less likely to develop this complication. Another unique side effect of cyclophosphamide is SIADH. This usually occurs in patients receiving IV cyclophosphamide for chemotherapy. They can develop hyponatremia, which can possibly lead to seizures. This is often compounded by the fact that these patients are getting lots of IV fluids to prevent cystitis. So the IV fluids dilute the sodium and lower the sodium level in and of themselves, and then in addition the patients can get SIADH, and the result can be that the sodium level can get very, very low. The mechanism of SIADH in patients on cyclophosphamide is complex. There is evidence that there's more ADH release when you are taking cyclophosphamide, and in addition the kidneys are less responsive to what ADH is present in the plasma. Our next drug is azathioprine. Azathioprine is used in transplant patients. It's also used in autoimmune diseases. It is a prodrug that's converted to 6-mercaptopurine, or 6-MP, which is a chemotherapy agent. I discussed this in the module on purines in the biochemistry section, and the reason I discuss it in the purine video is because 6-MP is an analog to hypoxanthine. Hypoxanthine is a purine. This is its structure at the bottom of the screen. Just like adenine and guanine, it is a base that can be attached to nucleic acid. This is the structure of guanine in the middle of the screen. You may know guanine is the base found in the nucleotide guanosine. And 6-MP looks just like hypoxanthine and guanine, so it will mimic their structures. By mimicking their structures, it will compete for binding to an enzyme called HGPRT. HGPRT stands for hypoxanthine guanine phosphoribosol transferase, and it's got the words hypoxanthine and guanine in the name of the enzyme to remind you that 6-MP mimics these structures. Normally, HGPRT plays an important role in the purine salvage pathway. It converts hypoxanthine into inosine monophosphate, also guanine into guanosine monophosphate, and by performing these actions, it allows bases to be scooped up and placed back in nucleotides so that they can be used again in the synthesis of DNA and RNA. That's why it's called the purine salvage pathway. Here's a slide depicting the normal function of HGPRT. It salvages purine bases like hypoxanthine and guanine and adds them back into nucleotides. If you add guanine back into a nucleotide, you get GMP, whose structure is shown on the screen here. If you add the base hypoxanthine to a nucleotide, you get inosine monophosphate, which can then be converted into AMP and GMP. And thus, as you can see from this slide, the enzyme HGPRT is important for the salvage and synthesis of new nucleotides that are purines like AMP and GMP. Because 6-MP mimics the structure of purine bases, it will bind to the enzyme HGPRT just like purines do. HGPRT will then incorporate 6-MP into a nucleotide structure. This will create a mutant nucleotide structure called thioinosinic acid monophosphate, and that is toxic to cells, and that will lead to decreased synthesis of purines like adenosine and guanosine. The main side effect of azathioprine is bone marrow suppression. This occurs because the blunting of purine synthesis leads to not enough nucleotides around for bone marrow cells. In addition, in the GI tract, there can be side effects like anorexia, nausea, and vomiting. And then a very high yield point to remember about azathioprine is that you have to be very careful if you give it with allopurinol. Allopurinol is a gout drug. It is a xanthine oxidase inhibitor, and it blunts the metabolism of purines into uric acid, and that's a good thing for gout. However, it also blunts the metabolism of 6-MP in azathioprine. 6-MP is metabolized by xanthine oxidase into thiouric acid, which is an inactive metabolite. If you block xanthine oxidase, you will get more activity of 6-MP, and this increases the risk of adverse events. Our next drug is miramonab CD3. It's also sometimes called OKT3. This drug is a monoclonal antibody that is used in organ transplantation. It binds to the epsilon chain of CD3, and recall that CD3 is the surface marker of T cells that is responsible for signal transduction. When T cells bind their unique antigen, it is CD3 that carries that signal into the cell to exert its effects. So by blocking CD3, you will block T cell activation, and this ultimately leads to T cell depletion from the circulation. A unique side effect of this drug is the cytokine release syndrome. It will initially bind to CD3 and activate T cells. This occurs after the first or second dose. Patients get fever and rigors and nausea and vomiting, sometimes diarrhea and hypotension. They can even sometimes have chest pain and dyspnea or wheezing. People have reported arthralgias and myalgias. Essentially, they look very sick because cytokines are flooding from the T cells that are bound to this monoclonal antibody. This is caused by, as I said before, initial activation of T cells and release of cytokines, and this side effect is minimized by pre-medication with steroids and antihistamines to block the effects of the cytokine release. Our next drug is infliximab. This is an antibody against the cytokine TNF-alpha, and it's used in rheumatoid arthritis and sometimes in Crohn's disease. It's called a chimeric antibody because it contains both mouse and human components. The antigen binding portion of the molecule comes from a mouse, and the constant Fc domain comes from a human. The problem with this drug, and with all drugs in this class, which we'll talk about on the next slide, is that they can lead to reactivation of tuberculosis. So you have to do a PPD screening test prior to starting therapy with this drug, and patients who have a positive PPD need treatment for latent tuberculosis before you start therapy with this drug. There is also a risk of other infections such as bacterial infections and hepatitis and herpes zoster. So infliximab is one member of a class of drugs called TNF-alpha inhibitors. Other members of this class include adalimumab and golimumab. Both of these are monoclonal antibodies to TNF-alpha. And then a final member of this class is etanercept. This is made by recombinant DNA technology, and it is a recombinant protein of the TNF receptor. It is a very interesting mechanism. It functions as a decoy receptor, so tumor necrosis factor alpha will bind to etanercept instead of binding to its actual receptor, and as a result there will be less TNF-alpha available in the body to exert the effects of the cytokine. The final two drugs I'll mention in this module are two malaria drugs called chloroquine and hydroxychloroquine. I talk about both of these drugs in the module on malaria infections, but these two drugs also have several immunosuppressive actions. They can block toll-like receptors in B cells, which leads to decreased B cell activation. In addition, they are weak bases, so they get inside cells, and in particular, they can get inside lysosomes, and this raises the pH and decreases the activity of immune system cells. They've also been shown to have a number of other actions which are effective in suppressing the immune system. As a result, you will commonly see people on these drugs for treatment of rheumatoid arthritis and also for lupus. And that concludes our module on immunosuppressants.